Good morning. I'm Dr. Rodney E. Rohde. I'm Regents Professor and University Distinguished Professor from Texas State University's Medical Laboratory Science program.
So, Rodney, what is the current state of clinical placement shortages in the US?
Yeah, so this is a problem it's not a new problem, Olivia. It's been going on for probably a decade or more. And it's not exclusive just to the medical laboratory. It's also seen with nursing and physicians and other areas of the healthcare occupation list. So the current issues with us, I'm just going to speak primarily about us, is that regardless of area, rural versus urban, regardless of state, regardless of program type, whether it's a hospital based or a university academic program like ours, we are seeing significant shortages for clinical placements. And just to define that for your audience, a clinical placement is a requirement for most of our programs. So students come through in the United States and they have to do the typical education, didactic, lecture, and laboratory coursework for several years. And in their final year, they're placed. We call them clinical placements. Sometimes you'll hear terms like internships or clinical internships, all kind of the same thing. And they go out, and the idea is they go out and they work in the workforce with a supervised preceptor, someone who watches them and teaches them in the clinical area. So they're literally working in microbiology, blood bank, hematology, clinical chemistry, and other areas of the lab. And those are just getting to be more and more difficult to obtain from different hospital and healthcare systems.
So, what are the key factors contributing to this shortage?
Yeah, so it's a really complex problem, but we'll kind of talk about maybe some of the primary issues, which I think most people would agree on. And that is, first and foremost, is just the shortages of supervisors and clinical preceptors in the workforce. And in a more deep understanding of that is that there's an overall workforce shortage in the healthcare arena. So whether you're talking about the medical laboratory or physical therapy or nursing or whatever area, we are seeing more and more people leave the field due to retirements. This has been ongoing again for more than a decade. And then, of course, COVID, there's been a pandemic effect, I'm sure, across the world in healthcare, but certainly in the United States, we have seen people leaving due to burnout, just overworked. Back during the height of the pandemic, some of my alumni were working just crazy numbers of hours without any rest, 10, 12 days in a row of 12-hour shifts and not much help. So sometimes you just have two or three people covering a floor, and it just got to be, overwhelming, especially long term when they were doing that for just months and months and years at a time. And so some left the field, and that's problematic. And then one of the other key factors for those shortages is it's linked to pay. And so pay has gotten a little bit better for the medical laboratory in the US, but we're still lagging behind nursing and other areas. So, over all those things, it kind of impacts job satisfaction. It impacts a lot of things. And so what you have is this perfect storm. And ultimately, trying to place students into those places, into hospitals, facilities, and even into public health laboratories within different states, or even reference laboratories, which are more industry based, like LabCorp, Quest, and places like that. They just don't have the people sometimes to give proper supervision. So what they do is they start limiting the numbers of students. We're also competing, I should mention, with multiple programs in our individual states or regions. And so that impacts it. And so over time, again, this perfect storm develops where it impacts the academic program. And perhaps we'll talk about that some too today, but it's just, I always talk about it in terms of it's a really nasty and vicious feeding frenzy. It's this circle of impact, because once that occurs, then it also impacts the number of students that I can take into my program. For example, I take 20 a year and I get 30 to 50 applications. I'm actually turning away people to come into our major because I can't place them. And so that's a dangerous circle effect, because hospitals need help and we're not providing as many graduates. And so it's kind of this back and forth damaging situation. There's just multiple things we're trying to do to try to alleviate some of that.
So then how does this lack of adequate placement hinder the practical skills and the experience of that's necessary for these professionals trying to come in and get these placements and go into the work field?
Great question. So just imagine if you, I'm going to put it in terms that, again, the audience, if they're listening and they're not familiar with healthcare, it might terrify them. Imagine that you had pilots or engineers or anyone else that you might know that graduated without any practical practice. So all they did was simulation. All they did was sit in the box and practice it through gaming or something like that. That's kind of our worry, is that, and I often use the analogy, you can't swim, you can't learn to swim without getting into the water. And that's the field of medical laboratory, or, I'm sure nursing and anything else. It's really difficult if you can't give students these experience, or you trim them down. So we're also seeing sometimes that perhaps, maybe one of the ways we deal with this is that we cut back on the number of hours that these students are required to do to gain competency in all these critical areas. And you can see the impact of that. I mean, you can just logically understand that if someone only learns something through a book and maybe practices, they do practice here in our academic centers and hospital-based programs, but it's not the same. It's not the same as working in an actual medical laboratory with all the stress and all the multiple things that are going on and being thrown at you. You need that practical experience to kind of trial by fire. And so it can and does impact competency and quality patient care. And it's hard to put a number on that, but certainly logically you could see that if you start limiting that experience of our students, it's going to impact them professionally. They may need longer time to onboard. They may need more one-on-one supervision when they start their job, because they're just not ready for the actual workload and the stresses of the job. And so, it impacts everything with respect to patient quality and healthcare.
So are there any particular fields where this shortage of clinical placements is more pronounced? And if so, why?
Yeah, I think the one you hear the most about, at least in the United States, is at the nursing and physician level. And again, I think this is complex. It's a complex thing. It's certainly critical in the medical laboratory and respiratory therapy and other places. But I think you hear more about it, and it's written more about and spoken more about because nursing and physicians are patient facing. And so it's an immediate impact, and it's felt by the patient, and it's felt by the nursing staff and the physicians, because they're overwhelmed with, instead of having 4 to 6 to 8 patients, they may have 12 to, some other load that can be actually pushing the limits of their ratio of patient to healthcare provider. You don't see us. We're behind the scenes. We're in the laboratory. We're working hard to change that every day, to get out in front of the public and to let people know. But you still don't see us as a patient on a daily basis, and so you don't really see that kind of impact. And so, I'm not sure it's any worse in nursing or in the physicians or in pharmacy or anywhere else. I think it's probably very similar to what we're experiencing. In fact, I would say, I've mentioned this in my writing and speaking, I think we're at a national crisis in the medical laboratory with respect to shortages and clinical placements. And they very much are integrated in their issues, because you can't really deal with one without the other. And so I think we're right there with them, but you hear more about it in the U.S. with nursing and physicians.
So how does this shortage of placements affect or impact the capacity of healthcare systems to respond to outbreaks and other public health emergencies?
Yeah, it's really critical. I mean, I think, it's one thing to think about the hospital setting, the healthcare setting, versus what I think the public, and I'm sure this is going on where you're at, it certainly has happened in the U.S., the public health system. So in the U.S., we have the public health system, which is more federal and state government types of laboratories. And what we saw during the pandemic was, there's been a massive shortage in the public health space, the public health laboratories as well. And so, yeah, you can't respond as well when all of a sudden you have, a handful of people in a clinical microbiology or a public health microbiology lab versus maybe dozens of people that can cover and go full time and go shift work and all those sorts of things. So it really impacts the workload. The actual workload is going to be reduced, and then again, it can impact patient care and public health forecasting. If you can't test and you can't get a feel for the epidemiology of your region or state or country, you can't do good modeling. You can't do predictions about vaccine needs or antimicrobial needs, or where is the outbreak occurring and what do we need to do with respect to maybe quarantining certain areas, or whatever the scenario is. So it absolutely can impact both public health from a very 10,000 foot view of a certain region, and it can also impact the local patient right in that hospital. If you are dealing, I'll give you an example. In the United States, if you have a place that's more rural, it's out kind of away from the urban centers, they have a really hard time staffing sometimes because, people just may not live there to work there, and it's already short staffed. And so you could end up with a hospital, for example, that only has one or two people working the night shift, and they might be brand new because some of the seasoned veterans have either retired or are left or whatever the reason. And this is not seen, right? This is kind of just something we know in healthcare, is that now you have a workforce in some of these more isolated areas. And it can happen in the big areas too, but you really worry about these isolated areas where you have nothing but rookies working in the laboratory. I mean, it would be the same for nursing or physicians. If you have nothing but rookies, that's a problem, right? Because you always want a mixture. You see this in the military, you see it in sports, you see it in the workforce. You need a mixture of rookies, kind of mid-level experienced, and then seasoned veterans that have seen it all more or less, or have seen a lot of scenarios and have worked through problems, worked through outbreaks, worked through pandemics, worked through whatever the situation was, so that they have knowledge and institutional memory of how to deal with problems. And if you don't have that, you're setting yourself up, for potential patient morbidity and mortality, and to a greater extent, public health emergencies when that occurs.
So what solutions would you recommend for addressing this shortage and mitigating its impact that you just mentioned?
Yeah, so this is a big question, and one that my colleagues and I and many of us in the United States, and I'm sure globally, are constantly working on. In the U.S., I've been really fortunate and honored to be invited to be part of the ASCP, the American Society for Clinical Pathology Blueprint for Action workforce team. And so this is a national committee. It's also a coalition that has reached out to the other laboratory professional organizations like ASCLS and AMT and APHL and others. There's next several. And what we're doing is we've come together to try to start addressing some of these workforce challenges. And really, there's three big kind of tiers to that. It's kind of centered around visibility, raising awareness of the profession, to looking at how do we improve turning out more graduates, even to the point of being more unified in our professional titles, so people know who we are. And then one of the big ones that's happening globally is just really looking at our DEI, our diversity, equity, and inclusion criteria, to really start reaching into populations that we need to have working in our field, to look and talk and it be culturally similar, so that you have that in your workforce that helps. So those are kind of the big three areas. And I sit on a subcommittee. I chair a subcommittee for a really looking at how do you unify titles, how do you get programs to change their names, how do you increase college majors. So really that awareness and visibility piece around academic programs. So that's kind of a big start to your question. Practically what we're trying to do is we're getting together at the local, state, and national region and trying to get together on the same team. There's a lot of organizations, there's a lot of healthcare systems, there's a lot of people. And you know how that can be hard to kind of turn that ship when there's so many involved. And so we're working on that. We've been working really hard for about a year now, and we are seeing some effects. I'm actually putting my own program. I just had it approved to change it to medical laboratory science, which is our credential. Medical laboratory scientist is the bachelor's level. Medical laboratory technician is the associate's level, the 2-year degree. And so we're trying to get programs across the country. We're at about 70+% now that use the same title. So what does this matter, you might ask? Well, it matters because high school students and even lower level students, junior high, kind of mid school level, all they ever hear is biology, chemistry, pre-med, nursing, physical therapy, veterinarians, and those are all wonderful professions. I have many friends that are in those professions. What they don't hear is the medical laboratory. They don't hear it as a college major. And so we need students and their families and their teachers and their high school advisors and other people to go, hey, you love to do diagnostic, like laboratory detective work. Why don't you do that for a living instead of going to medical school? And so we need that to happen earlier. And so that's kind of on the upstream area, just getting the visibility and awareness out there to get more students. And then on the downstream, we need to look at our programs, because we need to find a way to accept more students. So it's one thing, we need more students in our majors. I mentioned I can only take 20. We need to find ways to bump that up to 30 and 40 in every program. Whatever their number is, they need to raise that quota. And so that means more hospital rotations. That means more relationships with healthcare systems, with industry, with reference labs, with public health labs. All of these entities have shortages, and so we need to work together to build that relationship. I'll tell you, Olivia, one of the things we run into is, this is real practical. I have a wonderful clinical coordinator who's like the head of putting these clinical placements together, and she'll have them cancel right at the last minute because they're understaffed or they have an inspection, a regulatory inspection, and it impacts us. And yet we have to kind of maintain and have kind of a nurturing relationship with that hospital. So we do everything we can to kind of hold on to that and to grow it. And then some will quit taking our students. And what we're working on, it's not easy, but we're trying to build stronger relationships with each individual entity, because what we know and what they know is that if they don't take our students don't apply for jobs at that entity. They don't know who they are. And so it hurts them too. And so we need them to get more students. They need us to get more applicants for employee. So it's kind of it's a win-win. Even if they only take one, we tell them it's really important, because if they lose contact with us, then our student base, students talk. And so if you have nobody there, they don't even have the opportunity to come back and go, oh, I loved this hospital because of this, this, and this. And they can spread that positivity to the other 19 students. So that's really critical. Another piece of the puzzle, and this long answer, is that over the past 20, 30 years in the United States, we have gone from, back in 1975, we had about 700 programs. It's 240 now, and that's the bachelor's level. We also have quite a few associates level, and so we've lost a big percentage of these programs. That has to do with cost. It has to do with several things, including reimbursement. So hospital labs aren't getting paid as much to do the work. It's complex, but we've actually kind of stabilized. We've actually cranked out a pretty good number of students, but we're still not meeting the demands of the workforce. If you look at our Bureau of Labor and Statistics, what we're seeing is maybe anywhere between 35 and 45% shortages of the number of graduates we crank out. The other thing that's happened that's kind of hidden in the data that I'll mention is that sometimes an associate's level, we call them MLTs, a medical lab technician, will want to become a bachelor's degreed person. So they go back to school or online, figure out a way to get that MLS credential. And so they're not new, if that makes sense. It's not a new person in the workforce. They're still there. So in some cases, that's great. We want people to get higher education and titles and have opportunities to advance, but that's not bringing in new people. So the recruitment piece is really critical. And then I'll kind of finish this up a little bit with saying we cannot forget our seasoned mid-level veterans. We have to make sure we retain. So retention's really critical, that we find ways to raise pay, that we find ways to increase job satisfaction. One of the critical areas that our workforce tells us is flexibility with their scheduling. Again, with awareness of what they're doing, kind of appreciation for what they do. These are all kind of hard to put a number on, but we have to find ways to let them know and the public know how critical they are to healthcare. I think I'll stop there. That's a lot, but it's just a really complex answer dealing with this issue, and it's why I'm so happy to be talking with you.